Hello everybody, welcome back to our series of NEET MDS 2021 Recall. In this video, we are going to see about the tooth preparation using air abrasion. So a question was asked in the previous NEET MDS exam from this topic. So the question they have asked was, the size of the alumina particle preferred by dentists to do a non-invasive tooth preparation using air abrasion and a high suction is. So we have to see what is the size that we use when we prepare a non-invasive tooth preparation. Okay, so the options given were 50 micrometers, 100 micrometers, 150 micrometers and 200 micrometers. So let us see what is a tooth preparation using air abrasion. So it is a non-invasive method. Okay, so it is a non-invasive method. It is a technique of tooth preparation that uses kinetic energy to remove carious tooth structure. So it uses kinetic energy to remove carious tooth structure. So what we do in this, a powerful narrow stream of moving aluminum oxide particles. So a narrow stream of moving aluminum oxide particles hit the tooth surface and they abrade it without heat. So heat is not produced in this tooth preparation. Vibration or noise is also not produced. In our normal cavity preparation, we drill the tooth, right? We get the heat, vibration, and we even get noise. So in this tooth preparation we don't get any of them, and what we use is a narrow stream of moving aluminum oxide particles. So the commonly used size particle is 27 or 50 micrometers. So we use 27 size or 50 micrometer size of aluminum oxide particles for this kind of tooth preparation. Then coming to tooth preparation using air abrasion, we have variables that affect speed of cutting. So here in this image you can see, so this is a carious tooth, so like a minimal caries is there. So what we do, we abrade it with the high power suction, then we have a clean cavity, then it is filled with any of the restorative material of our choice. So variables that affect the speed of the cutting include air pressure, particle size, powder flow, tip size, angle and distance from the tooth. Okay, so that as the distance from the tooth ranges from 0.5 to 2 mm. So we put up the nozzle with at a distance of 0.5 to 2 mm from the tooth. So as the distance increases, the cutting efficiency decreases. So this is one more important thing. So as the distance increases, the cutting efficiency of the nozzle decreases. Okay. Then coming to the advantages that we have in this tooth preparation method is, it can be used to diagnose early occlusal surface lesions. So early occlusal surface lesions can be diagnosed with this, because when we put up such a high power suction, what it will do, it will abrade the particles. Then we can easily identify whether it is a carious tooth or not. So with that, we can also treat it with minimal tooth preparation. So minimal tooth preparation, we can treat the early occlusal surface lesions. So as we have seen, reduce noise, vibration and sensitivity. And air abrasion cavity preparations have more rounded internal contours. Okay, so the contour of the cavity preparation is more rounded like this. Okay, then those prepared with straight burrs. Okay, this may increase the longevity of placed restorations because it reduces the incidence of fractures and consequence of decreased internal stresses. So it increases longevity of restorations because it reduces the incidence of fractures and also consequence of decreased internal stresses. Okay, then coming to the disadvantages that we have, so it cannot be used in all patients. Okay, so it cannot be used for all patients. So what are the exceptions? Severe dust allergy, asthma, chronic obstructive lung disease, recent extraction or other oral surgery, open wounds, advanced periodontal disease, replacement of orthodontic appliances or oral abrasions, or subgingival caries removal, when subgingival caries removal is required. Why? Because we know that we provide aluminum oxide particles which are of very fine quality, right? So when we using these particles in severe dust allergy or asthma patients, that inhalation might trigger this allergy and asthma. Even it cannot be used in chronic obstructive lung disease. Recent extraction, why we don't do is these obstructive particles may get stuck in that extractive places and also in open wounds also. In advanced periodontal diseases, it might get accumulated in the gingiva. We have recession, right? We have pockets and recession. So if it gets accumulated in gingiva, that might cause a problem to the patient. And when there is replacement of orthodontic appliances and placement of orthodontic appliances and oral abrasions, of course, when this help in attracting those particles and accumulation in those appliances and abrasions. When subgingival caries removal is required, as we have seen during advanced periodontal disease, here also there is a chance of accumulation of particles in the gingiva. So this might lead to further infections rather than treating the tooth. Okay, so many of these conditions increase the risk of air embolism in the oral soft tissues. Dust control is a challenge in this method, and it necessitates the use of rubber dam. Okay, high volume evacuation, protective masks, and safety eyewear for both patient and the therapist. Okay, then coming back to our question, so what did they ask? The size of alumina particle preferred by the dentist to do a non-invasive tooth preparation method. So what size we use? 27 or 50 micrometer size of alumina particles are used. So we have one option of 50 micrometers in option A. So this will be the correct answer for this question. If you like our video, do subscribe to our YouTube channel. You can also follow us on Instagram at Docshala for dental content and at Docshala Medical for medical content. You can also find us on Telegram. Thank you.